there is a table that is front and back that at the top says Components of Comprehensive Diabetes Medical Evaluation. And then for treatment, you should have one that says Treatment of Type 2 and a color chart. Which, interesting, all the colored ones are gone and black and white stay. Now, what is that?
They were at the top.
It's Sarah Beth. I know it's her.
I like color, you guys. I guess we can make this.
You what? Okay, questions from this morning. We kind of left off with diabetes symptoms, like we're picking back up with those again in terms of, so what do you do when you get somebody who has diabetes or is not known to have diabetes? What do you do? So we're going to start off talking about the labs that you would run and understanding those. This is important because they're your bread and butter if you are dealing with people with diabetes. So the PowerPoint, I've just put them on here so I can talk from the slide instead of, I must not have that over here. Okay. So diagnostic tests for prediabetes and diabetes on page 3. They are the same. The criteria are different. So if you suspect that somebody has diabetes, there are 3 tests that are acceptable to use in order to make a diagnosis, or to at least obtain data that then would help you make a diagnosis. So one is a finger stick blood sugar. That is done usually with a fasting. So you do a finger stick, you do it in the clinic. We'll learn how to use meters next week. You can send them to the lab and get a venous draw. Either way. The one thing you want to know though, are they fasting? Okay? Fasting means different things to different people. Fasting means no calories. You didn't pop a cough drop in your mouth before. I can tell you there were a number of times where I got called down by the family medicine docs and goes, this patient's blood sugar is at 500. Will you talk to them? Only to find out that that is abnormal, but they took a swig of Coke before, or Gatorade, before they went in to get lab. It's like, didn't they ask you if you were fasting? Yes, I was, but I hadn't eaten anything. Yeah, you just drank a bunch of calories. Or that cough drop in your mouth has sugar in it. Okay, so make sure people understand. Usually, if you're dealing with someone who has type 2, you would like to have 2 determinations, especially if they're close to the border, because they can traverse. They can be one day be in the normal range, or not normal, but maybe impaired range, and the next day be in the above. So usually 2 is helpful. Now that we have A1Cs, though, you can actually do a finger stick at an A1C, and that'll nail it for you if they have abnormal glucose tolerance. Okay. But a fasting blood sugar is very reliable. It is also it's diagnostic. Usually 2, but 1 will do it. So we want them to at least have nothing to eat or drink, no calories for 8 to 12 hours. So that means whenever they're coming in. So be careful about when you tell people to show up for lab. If you schedule them at 1 o'clock and you want them to go to lab right before they come to see you, then they have to go a long time without eating. Okay, so schedule your labs on a day when they're not coming in, if they'll do that, and then it'll all be ready for you when you see them. Okay. So that's a finger stick fasting blood sugar. So let's see, under there, could screen, finger stick, definitive and inexpensive and reliable. So that's good. So that's why it has stayed the norm. It will not pick up everybody because it looks at a fasting, and based on what we talked about this morning, now you can see why. People can have pretty significant postprandial changes or increases in blood sugar, but their fastings can be normal, so it will not pick up everybody. But the people who it picks up, it's reliable. It tells you. It'll test abnormal usually all the time. Be careful about calling people diabetic unless you really know they're diabetic, because things start to affect you if you're diabetic. Your license, depending on what you do for a living, can be affected by having diabetes. Your insurance can be affected. Once you code them for insurance, it follows them for life. Okay, so when they need the diagnosis, give it to them, but be careful if you don't. Okay. So let's see the criteria. Okay, so we talked about those three things. The other is to do an A1C. So we're going to talk about what A1C is. So the picture there below is a machine that would be in a clinic. This is called a point of care test. So there's lots of things that you can do point of care test. You can measure an INR on a point of care test. So the device is only devised to do usually one thing, maybe a battery of things. But you can do these in a clinic if you have a special license. It's called a CLIA waived license, which means for certain tests, you can run them in the clinic without sending them to the lab. The nice part about this is you get the results right away. So in our clinic, we always did A1C as point of care testing because I could then talk to the patient right then. All of our INRs we did with point of care testing. So this is an older model. This is one of the Bayer models, and that's the device. You have cartridges that are in these little containers that are refrigerated. And then when you are going to test them, you take them out, let them warm up, prick their finger, very, very small amount of blood, run it in 6 minutes, you will have an A1C. Okay. So very nice in terms of discussing with the patient. Or you can send them to lab and do the same. But patients, once they figure out that you can do certain things with a finger stick, they'll much prefer that than to have to go and get a venous straw. So the nice thing about A1C is it's not influenced by the day-to-day changes in blood sugar.
I'm sorry.
Blood sugar is one point in time, that moment. Okay? Patients, if they get good enough, they can start to figure out how they make their blood sugar look the very best. Okay? So they're just a piece of the puzzle, which I always tell patients, just a piece of the puzzle. A1Cs take that piece out. Because what they do, you look on the next page, hemoglobin A1C measures how much of your hemoglobin A has a sugar attached to it. So when 90% of the hemoglobin that you have, for the most part, unless you have a thalassemia, most of your hemoglobin is hemoglobin A. When you are born, your hemoglobin is predominantly hemoglobin F. Okay, so hemoglobin changes over time. Not that the hemoglobin changes into something else, it's just the variant changes. So 90% of the hemoglobin in your red blood cells is hemoglobin A. Hemoglobin is a protein. I told you that sugars like to attach to proteins. They like to glycate them. Okay? Once sugar and hemoglobin form a bond, it never breaks until you get rid of the hemoglobin. Okay? So it's permanent change. So the life of a hemoglobin, what's the half-life of a red blood cell, or the length of life of a red blood cell? 120 days. So if your hemoglobin population or amount is stable, then your reading of how much is glycated is fairly stable, unless you got blood sugars going all over the place. The more unstable a blood sugar is, the more noise there is in the hemoglobin, or the A1C. Okay. So all of you have a percent of your hemoglobin that is glycated. And it is in proportion to what your blood sugars are. The higher your blood sugars are, the higher the A1C will be. Okay? Since most of you probably don't have diabetes, your A1C is falling in the range of about 4 to 5%. So 4 to 5%, or 5.5% of your hemoglobin A has a sugar attached to it. That's normal. The higher your sugar is, and for the longer it stays high, the higher that percent will be. And because the red blood cell is stable, fairly stable, then it gives us a way to look back over the last 3 months of what your blood sugar's been like. Yes?
Does that affect your oxygen carrying ability?
Nope. No. So it gives us a way to look back. So it is another piece. You got a blood sugar, they come in at 85, but their A1C is 6%. Well, then their postprandial rise is very high and prolonged for a long period of time. That's the way I would interpret that. Okay. So questions at this point. This is a very important concept. All right. So the 1% change in A1C represents about a 35% milligram percent or milligram per deciliter change in average blood sugar. So you can convert, but usually your lab will convert for you an A1C into an average blood sugar. Okay. So for ease, if we said an average blood sugar, average, was 100 milligrams per deciliter, that would translate into an A1C of about 5%. For every 35 you add, you go up in a percent. Now your lab will do it. They'll report out an A1C and they will give you an average blood sugar to the side. And they will range anywhere from 25 to 35 milligrams per deciliter per A1C. So it'll vary. I'll tell you this, but it will look different on your lab. But that's because of what they're using. Okay? So an A1C of 10%, I can eyeball that because I know the average is 5%. It's 5 points above average. 5 times 35 is 175. So I know that their average blood sugar is 275. Okay, that's average. That means they're spending half the time above there and half the time below there. Okay, so that's why that number is important. It also, because we've got long-term studies, we can tie an A1C to risk. Okay. So we know that for microvascular disease, the threshold's about 8%. Once you get above 8% and stay there with an A1C, your risk of microvascular complications goes up. Eyes, kidneys, nerves. Okay. So this number is important. You can diagnose with this number. So if their A1C is 6.5% or above, that is diabetes. So you come in, you measure their blood sugar, and wherever it is. Let's say their blood sugar is actually, their fasting is 110. If we went just by their blood sugar, we would call them pre-diabetes. A fasting blood sugar of 100 to 125 is considered pre-diabetes. 126 and above is considered diabetes. Questions about this? A1C, very important. One of our glycemic goals will be set on what your A1C is. For pre-diabetes, an A1C of 5.7 to 6.4% is pre-diabetes. So less than 5.7% is considered normal. Because we know that it correlates to what fluctuations in blood sugars are, and that has the lowest risk in long-term studies. Okay, questions? So if somebody has a variant, so this is fairly reliable. There's very few things that interfere. Now, if you have a hemolytic anemia and you're destroying red blood cells really fast, then A1C won't show up. If you've got a variant, if their hemoglobin is not mostly A, it will show up as normal or below normal. So that's what we count on. But most people are predominantly hemoglobin A. So that's what hemoglobin. I see a lot of head shaking, so is this a concept you're familiar with?
Mm-hmm.
How do you know that?
The lab or med objectives.
Oh, you've already done it. Okay, good. Good. That's good. All right. That's great. It's good to... the other thing that you can do, so you can use it as a diagnostic, you can use it in combination with blood sugar. We use it as a way to determine whether people are meeting glycemic targets. So it's used in monitoring and in diagnosis. People can do these at home. They can buy a machine over the counter and do it at home. Little bitty A1C test. So they're fairly common. And patients will understand and get used to that. It should be drawn about every 3 months. That's the standard, unless people are extremely stable, and then it's done. It can be done twice a year. To meet quality standards, the government just requires you to do it once a year. That is not enough if you're following somebody who has diabetes. Okay. Oh, if you look at drawbacks to A1C testing, if somebody's had a recent blood transfusion, it will mess it up. So a couple things let me tell you about diet for interpreting an A1C. A1Cs are most affected by what has happened in the last month. So 50% of the impact on an A1C is reflecting what happened in the last 30 days to that person. The other, let me go back over this again. If they have blood sugars, let's say they have fasting blood sugars around, 110 to 150. This is their fasting. But their A1C, let's say, comes back to 9%. Convert that 9% into an average. By what I just showed you. It's 4% over 5. So 4 times 35 is 140. So you add that back to the 100. So that's 240. Does that look like anything you're seeing here? Okay, so several things. If the patient has brought you in a logbook and that's what you're looking at, they could be making up their numbers. They do that because they want you to be happy with them and not yell at them and make them do something they don't want to do, which, what can you do? You can't make them do anything. But they want your approval and they want to think that they're doing okay. So they will fictitiously make up numbers for their, sometimes in their logbook, if they're handwriting. Okay. If this is true, let's say you're looking at a meter download. Let's say they brought in their blood sugar, their meter, and you downloaded the data, and sure enough, that's what their fastings look like. So what does that mean? What that means is that it's their postprandial. So their blood sugars are doing this after a meal. Okay? This is what's affecting the A1C. There's lots of sugar out there, and there's hemoglobin to be found, so it will attach. So that's what that's telling you, is that this is mostly postprandial. As a practitioner, I look at that and go, you probably need insulin. We need to put you on a bolus insulin and cover that big surge of sugar that you're getting after a meal. That's how I would use that. Okay? But in terms of interpretation, which I know you all sometimes struggle with, that's how you would interpret that. So that's what you're looking for. So also, if they've had a big change, did you stop taking your medicine in the last 30 days? Did you go on binge? And did you go on a cruise and you ate like it's, you know, tomorrow's not going to be here? So it could be that. So the other way I use it is that I have somebody come in. This would be a common person I would get in family medicine. A1C's 12 to 16%. Pretty common. Start them on insulin. Okay, so I would do that, and they would come back in a month after we had kind of titrated their insulin, and now their blood sugars, instead of being 300 to 400, now they're running about 150. They're feeling better. Their symptoms have gone away. And so I will repeat an A1C because I know the last 30 days is a huge impact. Not because I know it's where they're going to end up, but because I can encourage and I can show them. Your A1C is now 8%. Look at all you've done. Look at how good you've done. Look at what that insulin's done. It's an encouragement. It's not where they're going to be, but I use it that way to give them feedback, to say, pay it off. This is good. All right. Questions about A1C? So know where it comes from, what it's used for, being able to kind of eyeball it and look at what an average would be. I know your lab can do it, but I'm telling you, often it's just good if you can eyeball it and go, this is it. Or you can look at their A1C and their blood sugars and go, okay, something's not right here. Okay. All right. An important test. Okay, then on page 5, the oral glucose tolerance test. How many of you, when you were pregnant, had this done? Some degree, yes. All pregnant women get a form of this done to detect gestational diabetes. So an oral glucose tolerance test is what it's doing is it is really trying to replicate what happens after a glucose load, like when you eat. So if we can give people a known standard amount of glucose, 50, 75, 100 grams of glucose when they're fasting, and then we can check their blood sugars. And we can look and see what is it as an hour, what is it at 2 hours, what is it at 3 hours if we need to go out that far. So we'll check their blood sugar before they drink that glucose. And it is sickeningly sweet. So here's their blood sugar at some point in time. They take that glucose load, and then we measure them at 1 hour, 2 hours, and maybe at 3 hours. And there are standard ranges for each of those. Okay. I don't remember what this one is, 190? Did I put it in your chart? I think the 140 is at 2 hours. 199. So if it's above this, you can pretty much call it. But a lot of them will go out to 2 hours because this one maybe will be a little bit lower. But what happens is their curve tends to be like this. So if it's greater than 140, I believe at 2 hours, you can also call it. This is the most sensitive test for if you really aren't sure. If you've got somebody, let's say they've got complications. Here's a patient showed up in our clinic. Sent over from ortho because they said, pretty sure she has diabetes. Presented with neuropathy. Blood sugar is pretty normal, but when they did an oral glucose tolerance test, that's where it showed up. So you can tell this is definitive because it's that postprandial load that they cannot handle if they have some degree of beta cell dysfunction. Okay. So this one you won't order very often, but it sure can tell you if you're unsure or if you really need the patient to understand and be sure. Okay. So a fasting will catch your people who have impaired fasting glucose. Your A1C will help with that. But if you've got an abnormality in the hemoglobin, it won't show up. This one is definitive. So it's the most sensitive, yes.
Is there a difference between the finger stick and the venous drop? And the reason I'm asking is because at least when I had this, they did the drop instead of the finger stick, but it seems like the finger stick would be cheaper.
They'll always do a venous on this one. Well, because there's more variance allowed in those finger sticks.
Okay.
So around a mean, they can have more variance. They also have to, when you're doing that kind of diagnosis, you want it to be as close as possible and most accurate. So I've never seen you do a finger stick with an OGTT. Yep.
Okay, thanks.
But you can do a finger stick to diagnose. You can't do that. Okay, questions about this one? Okay. All right.
It's the same thing. The lab medicine notes from yesterday, it says 180, 155, 140 for the three.
Okay.
Is it okay? Or I just didn't know which ones you were.
I wonder if that's the gestational. The
maybe it's
gestational has
gestational.
different ones.
Okay.
I would probably be most interested in this one. I want you to understand what it's used for. I mean, I always have to go back and look at the numbers because I don't do them very often. Also, patients hate it. They have to sit there for 2 to 3 hours, so they hate it. The 3 hours, they rarely go out this far. It would only be as if these two are close and you want to see if that third hour does it. So most people are called within the first 2 hours. So it's the inconvenience. Just
when I had mine done for my pregnancy, my first one, or my second one, they just did like the 1 hour, and then I failed that one. Because, I mean, I just always think, because they told me, well, you can eat before it, but I went and ate a whole bunch of carbs before I did it, because I wasn't really starving. And so I failed it, but the second time I didn't fail it. Is there, I mean...
Okay, you raise a good point. What we do with pregnant women and what we're doing here are different.
Okay.
So with pregnant women, the one that they usually do is a screening only. So they come in and they give you do they still give you a load?
It's like a drink.
And then they'll do a 1 hour. If you're below, they don't mess with going to a full one. You only do a full if you fail those. And most women that go on to do the second one pass, just like you did. If that's a word. Okay. So this is not what they do in pregnant women. I mean, this would be what they do in pregnant women who have failed the first screening. Okay. So more, I want you to know its place, why we do it, the intention of it. This will tell you impaired glucose tolerance, IGT. This is what this one tells you. Okay, question about that? Okay, diagnosis of diabetes on 5. You must know these. So an A1C, it should be underlined, the 6.5 or greater. A fasting blood sugar of 126 or greater. And when you see that, you want to make sure nothing is influencing it. If they're sick, if there's a stress going on, then you would repeat it. Okay? Because those things will raise it. The last one is important, it's different. So it is a random, meaning that the sugar is taken without regard to when the meal was. Whenever you have a blood sugar, you always want to know when they last ate. If I'm a good shepherd with you and you come out of the room and tell me their blood sugar is 160, the first thing out of my mouth is going to be, when did they last eat? Sugars mean nothing if you don't know when food was taken in. Okay? All right. So a random, greater than 200, with signs and symptoms of hyperglycemia. So think back to what we talked about at the end of the hour before lunch. So high blood sugars, the 3 Ps, polyuria, polydipsia, polyphagia, weight loss. Okay. So they're peeing a lot, they're drinking a lot, they're eating a lot, but they're losing weight. Those are symptoms of hyperglycemia. Most common. If you have somebody walks into your emergency room or your urgent care and is complaining of that, you get a blood sugar of 220 and they have those symptoms, you can call it, you can say you got diabetes. In the past, we would have said you have type 1, but anymore you can't tell, so you would send them on to more, for greater care. So classic symptoms of hyperglycemia are the 3 Ps, polyuria, polydipsia, polyphagia. Or an OGTT with a 2-hour greater than 200. 200 or greater. Okay. Yes?
For diabetes, either one of these tests can be definitive. For pre-diabetes, is it the same, either one of these tests in that range, or does it need to be multiple for pre-diabetes?
For pre-diabetes, you won't see the random.
Okay.
It will be an A1C of 5.7 to 6.4, or a blood sugar, a fasting blood sugar of 100 to 125.
Okay, so it can be or not, it doesn't need to be both for
Doesn't need to be both. Diagnosing type 1. So because type 2s can present with DKA, in the past you never saw it or we didn't know. We may not have appreciated it. But now we have drugs that can make people present in DKA. The second generation atypical antipsychotics, remember those? They are probably the number 1 drug-induced cause of DKA. So they can do it. Another class of drugs that can do it are the SGLT2 inhibitors for the treatment of diabetes. We'll talk about those later this afternoon. So you really don't know. Used to, type 1s would come in and they were skinny and they were losing weight and you knew they were type 1. Now, since everybody's heavier, a type 1 can come in, they can be heavy, they can be fat, so you can't tell anymore. So what we do is we can draw antibody levels. So since type 1 is an autoimmune disease, we can draw antibody levels. Now, they're not always positive, but they frequently are. So the ones that are the autoimmune markers are islet cell antibodies. Duh. Okay. These are very common. Another one is autoantibodies to GAD65. That's probably one of the most common ones we draw. Insulin antibodies. Tyrosine phosphokinases. These are intracellular enzymes. So we draw these. They have different time profiles. GAD is probably positive in 65 to 75% of people. When Dr. Vanetta was diagnosed, because he's so atypical, they did antibody levels, and he'll tell you they were normal, or there weren't any available. So, because he was a skinny person, active, showing up with diabetes, they're thinking, you're type 1. Has he told you all he's diabetic? Okay. So anytime I've got a kid, teenager, or younger person, I'm always going to do this. But if I've got an older person who is a skinny type 1 who's showing up with symptoms that are very much telling me they're insulinophenic, what would tell me that they're not producing much insulin? What would tell me?
Hyperglycemic symptom.
Pardon?
Yeah, the hyperglycemia.
Hyperglycemia and weight loss. I'm telling you, weight loss to me is big. If you're losing weight, then you're not making insulin, and you're skinny to start with, then I'm going to draw these, and they take a while to get back. So we're going to treat the patient's symptoms. We're going to treat them symptomatically, but we'll wait to see what the enzymes or the antibodies come back. These are important to know. It's helpful. I worked with the peds group a lot. I didn't do kids because at OU, the peds endo was so good. Their program is excellent. But I knew what they wanted. So one of the things, I hear you all talk about that too, is I want to know from the specialist, what do you want from me before I refer them? And so I figured out early on is that the peds folks wanted the antibodies drawn because they do take a while to come back.
Do you
Yes.
draw all of them? Do you run all of them?
You don't have to draw all of them. I usually did the GAD and the islet cell, but I have done insulin. I didn't usually order the tyrosine, phosphokinase. There's timelines on them. I didn't write them down, but that may be another thing I need to send you all, is if there's a timeline, is how far out you think they are and when they're still positive. Okay. Questions about those? Those will be definitive. If you've got positive antibodies, then they've got type 1. Okay, diagnosing type 2. So again, it's fasting plasma glucose, a 2-hour glucose after a glucose load, a glucose tolerance test, or the A1C, all are appropriate. Confirming, unless there's a clear diagnosis. So if their blood sugars are greater than 200, classic signs and symptoms, you can call it. Okay? That's clear cut. Then repeat the same test. You've got an A1C of 5.7 and you've got a slightly elevated blood sugar. Repeat the test. It doesn't mean the person isn't at high risk, but you may not call them diabetes. Okay. Questions? Okay, so who should you screen? All those risk factors we talked about, that is who you need to screen. There are guidelines on certain folks with certain characteristics and when to do it. It's recommended that everybody, starting at the age of 45, if they have not been screened before, start your screening at 45. If they're normal, if everything comes back normal, then you can wait 3 years. Because enough is not going to change in 1 year to justify it. So a lot of studies have looked at this. So every 3 years until they are no longer there. Patients with prediabetes ought to be screened every year. So once they've fallen into that A1C of what? What was pre-diabetic A1C? Once they've fallen into there, or they've got a fasting blood sugar of what? 100 to 125. Once they're there, then you need to repeat at least every year. Because people, 20% of pre-diabetics move to diabetes every year. If you fall into the pre-diabetic range, the likelihood that you will have diabetes in 5 years is about 100% if nothing is done. Okay? That's why it's high-risk pool. Identify them and intervene. Women who have been diagnosed with gestational should have lifelong testing, at least every 3, but I would say every year, depending on what their results were and what their risks are. They are going to have type 2. Now, who else who you look at? First of all, look at weight. Weight is probably one of the strongest correlates here. So if they are overweight and they have one additional risk factor, okay, so they're overweight, they don't exercise. They're overweight and their mother has diabetes. They're overweight and they are Asian American, African American, Native American. Then screen them. If there's somebody who had a history of gestational diabetes and they're overweight and they haven't been screened in a few years, retest them. For your moms that have gestational diabetes, strongly lay it down with them. Your risk for type 2 diabetes is very high. It's likely in the next 10 to 15 years you will be diagnosed with that disease. You need to be screened frequently, and you need to get walking, and you need to lose weight. In between pregnancies, the greatest way to lower your risk for a second pregnancy with gestational diabetes is to be active and lose weight. The hardest things, the easiest things come out of your mouth, and the hardest things for them to do. For people who are hypertensive, dyslipidemia, those little spikes of the peaks of the iceberg. If on previous testing they come in and they tell you, well, have you ever been told you had an abnormal blood sugar? Yep, I did. Yeah, they told me that about 3 or 4 years ago. I was at a screening. I went to health fair and they told me my blood sugar was, 150. That may not count, but it ought to make your ears go up, perk up. Physically inactive, we talked about that. PCOS, those people should be screened. Other conditions associated with insulin resistance, you find acanthosis nigricans, there needs to be a blood sugar drawn, or a history of cardiovascular disease. These are important. I will ask you about these. These are the folks you need to be able to identify walking in the door. If you will do that, you will save them a lot of grief if they listen to you. Okay, what about kids? What do we do about kids? Test children for diabetes if at 10 years of age or at onset of puberty. And then every 3 years. Fasting is the preferred. So what's the criteria? If they're overweight. Now for kids, the overweight goes to what percentile they fall into. Y'all talked about growth curves. So they'll be on a growth, they'll plot. Every time the kids come in, they'll plot them on their growth curve. And they'll look, because you usually stay on your growth curve, your weight curve. So they're going to look at what their percentile, where they fall for age and sex. So that we're looking at kids whose BMI is 85th percentile and above, or their weight is 120% ideal. So they've got those charts posted. You go in with your kids, or they have a posted on the wall. So if they're overweight and they have any of these risk factors, so you got a family history. Your mom has diabetes. Here it's a second degree relative. So see, that's where the parents aren't old enough maybe to be diagnosed. Member of an at-risk group. If you live in family medicine or work there for a long time, you're just going to see family waves come through. And if you follow them long enough, you just watch them. The parents are overweight. Kids are overweight. You keep following along. Kids get mom and dad have diabetes. Kids get diabetes. It was not unusual for me to see couples who were 300 and 400 pounds apiece who had 10-year-olds that are 200 pounds. Was not uncommon. Not uncommon. So it's almost a family approach. When you're dealing with diabetes, you really have to treat a family. Because if it's the mom, she is buying food for everybody in the group. If there are teenagers, to me, teenagers drive what is in the house. Kids drive what is in the house. If you're a grandparent raising grandchildren, and a lot of people in this state do that, the grandchildren drive what the grandparents eat. Most people can't afford to have separate foods for everybody in the house. So your kids and your teenagers don't want to eat like an old diabetic. So you've got to address the household. I had more than one family conference with people. When I could not make any headway, I would sit down with the family and go, here is what is going on. We would do it as a team, a medical team. Here's what's going on. If things don't change, here's what's likely to happen. Just lay it out for them. Okay. History of maternal diabetes or gestational. So now we know that just mothers that have gestational diabetes are more likely to have infants that are at risk for diabetes later in life. So, kids, overweight, plus 2 risk factors. At-risk ethnic group, family history. Or they've got some other signs and symptoms. PCOS will show up in teenagers. They'll start, as soon as they hit puberty, they will start assuming that body habitus. They usually are girls who are going to have irregular periods. Or their periods start and then they don't have another one for months. So that is a very common history. Small for gestational age. I think it has something to do with the ability of the pancreas to grow. Moms who smoke tend to have babies that are small for gestational age. We can give birth to preemies that are very young and those organs do not develop. So it seems like it's capacity limited more with the children that are born preterm. Okay. All right, so if you're in peds, looking for those. Other populations, HIV patients, especially if they're on they'll all be on antiretrovirals. But those drugs are very diabetogenic. So checking them annually, if you find a glucose intolerance, then checking them on a regular basis. This recommends every 3 to 6 months. Patients prescribed atypical antipsychotics. Remember I gave you that big chart, that table, and I told you that psych hospitals are now under the gun. You don't do this, you don't get reimbursed. You have somebody admitted to your facility, you send them out with prescriptions for atypical antipsychotics. You have to show them that you are monitoring their blood sugar. That's one of them. Diabetes is huge with that group. Okay. All right, questions? Who to screen? Who should be on your radar? Okay. All right, let's take a break, and when we come back, we'll pick up and talk about what do you need to get in a medical history. So if you'll kind of keep this table out there with you as we go through that, we'll talk.